Dockett, Senior Writing. Happy to be here with you and with Regina Koepp to dig into the topic of older clients and sex. Regina did a great piece for us in the September-October, I'm going to pull it up right here, issue of the magazine called Sex and the Older Couple, who look like they're having a nice time there, helping partners reimagine desire. But before we start digging into what she shared, I'm just going to give you a couple of instructions for as we go along. So if you don't already subscribe to Psychotherapy Network or magazine, your presence here today entitles you to a deep discount. So just follow the link that will pop up on your screen to take advantage of that. And Regina has also provided a link to her sexual health assessment toolkit for working with older adults. And we will pop that up periodically during our talk. But do check that out as well. It's really, really helpful. As we get going, please feel free to comment, ask questions in the chat throughout the talk, and we will get to them as we can. Okay, so for an intro, Regina Koepp is a Stanford-trained clinical psychologist and geropsychologist. She's the founder of the online training resource Center for Mental Health and Aging. Currently, she's the lead medical psychologist at the University of Vermont Medical Center, and she hosts the podcast Psychology of Aging, which, if you work with older clients already or are interested in these issues, I heartily recommend. I find it very compelling and accessible. Prior to all of these roles, she was assistant professor at Emory University Medical School and staff psychologist at the Atlanta VA healthcare system, where she provided mental health care to older adults and caregivers for more than a decade. So Regina, you know this work. And we found, despite the good work you and others are doing in this area, when we were working on this issue, we found that the field itself doesn't always seem to be gung-ho, even just about doing therapy with older adults, generally, not to mention working on issues of older sexuality. So if you don't mind, let's just unpack that at first for a bit. What are some of the ageist tropes that you find yourself exposed to over all these years doing this work that therapists themselves have to kind of dismantle to become more open to and better at working with this population, whether or not they're working on sexuality with them?
It was such an excellent question, and thanks so much for having me and for the invitation to write this article, and to Psychotherapy Networker in general for just devoting an entire issue to aging mental health and including sexual health. So it's, for decades, I have been sort of a cheerleader for mental health providers, or to mental health providers, about older adults, because I think working with older adults is one of the richest, most exhilarating patient populations that you could ever work with. And I'll share a little bit more about why. I think in terms of some of the ageist tropes, I would say that we see some actually already in the comments. Some of the comments that I'm seeing are, your sex life dies with age, and that is indeed an ageist trope. I'm happy to share some statistics on older adult sexuality and sexual expression, and that older adulthood is a difficult age. So there are ageist tropes like it's not for wimps to grow older, or you have to have a good sense of humor to get older, or of course you're depressed, you're old. Everybody's depressed when they're old. Mm-hmm. And that's a ageist trope, because that's not true. Depression is not a normal part of aging. And depression, even during the COVID-19 pandemic, of course, older adults, especially before vaccines, were the most vulnerable to COVID-19. But CDC did a study and looked at different age groups across the lifespan and looked at vulnerability for mental health conditions like depression, anxiety, post-traumatic stress reactions, suicidality, and substance use, and found that older adults were the most psychologically resilient age group. Yeah. And so but we overlooked that by and large, actually. And even older adults, so I think something like 5 universities got together and did a study about depression among older adults, and found that even older adults who before COVID were living with depression and seeking treatment for depression actually had high rates of resilience during COVID as well. So we know that it's actually a phenomena that happens with aging, not just this group of older adults, but has happened throughout decades and generations, that as we age, we become more psychologically resilient in general.
Yeah.
Of course, there are people who struggle like any age group, right? And so mental health is incredibly important even for older adults, because when mental health conditions go untreated, there's earlier mortality, there are more medical problems, there's more cost for medical problems, there's more caregiving strain and more cost associated with caregiving, and so on. So the good news is that mental health conditions can be treated in older adulthood and at the same levels of efficacy at any other age group. So that's another ageist idea, that older adults are rigid and will never change.
Right.
And that's not true.
Right,
Older
right,
adults
right.
benefit from treatment. So that's just like generally about older adults. And then there are ageist ideas about sex and aging, which is at a certain point in life, don't people just lose interest?
Yep.
And aren't you too old for that? Or the opposite, if you are interested in sex, then you're perverse or perverted. It's not normal, it's deviant. And of course, that is not true. And it promotes a lot of shame and stigma for older adults, who the majority of whom are remaining sexually active in older adulthood. So there was a recent study, it came out in 2021, that surveyed 1,000 adults between 65 and 80 years old and found that close to 81 or 82% were still sexually active.
82%.
Yeah. So
Well,
close
it's like compared to the general population, it even seems almost as high.
Yeah.
As the general population.
Yeah, that's a good question. There was another study that was done prior to that that looked at younger age groups as well. And while the prevalence does decrease, the majority of older adults are still engaging in sexual activity. And that could be with a partner, or that could be with oneself.
With themselves, yeah.
Yeah.
Okay.
And then that earlier study, not the one in 2021, but one from some years ago, also looked at, but surely the frequency wasn't as often as younger age groups. And the study looked at that and found that indeed the frequency was the same frequency. Older adults are engaging in sexual activity with the same frequency as other age groups.
So surprising.
Yeah.
Really is not what we think. And that is a trope. You talk about this phenomena of therapists often not even asking their senior clients about their sex lives, that in healthcare settings in general, it's often the clients themselves who end up initiating these kinds of conversations. What is behind that, especially in these clinical fields?
Yeah, well, I would say ageism exists everywhere in the community, in our minds and psyches, and in healthcare systems, and including with our doctor, including in our mental health, clinics, and including in couples therapy sessions. So I'll work with couples therapists who won't ask couples, about older couples especially, about their sex lives, even though they're doing couples work together about their relationship. And sometimes there are generational differences where I'm uncomfortable. If I'm a new mental health provider and maybe I'm 30 and I'm asking an 80-year-old couple about their sex life, that's awkward. Like I've been taught to respect my elders, and is it intrusive to ask these questions? Or and so I think there are some generational differences that need to be navigated and reflected upon, so that the therapist herself or themselves can challenge those and inquire anyway in a respectful way, or even talk about the generational differences. So that's one of the barriers. So I think it can be uncomfortable to ask, and that you might have to bridge some generational differences about how we talk about sex, the familiarity with which we talk about sex. That I could be, as I'm 46, and if I'm working with an 80-something-year-old couple, they could be my parents. That can feel very awkward. But we do this work, and we do awkward work as mental health providers all the time. We can do this too. And it's an enjoyable and meaningful and deep and rich conversation to have. So that's one thing, and some of the barriers. I would say too that in terms of like a health clinic, like with a physician, time is limited for many physicians. In managed care, we know that time is limited. So if somebody's coming in with diabetes and heart disease, the first question, and you have 15 minutes with your healthcare provider, sex might not be the priority to the health provider, even though it might be the priority to the older adult. And so that can be tough to sort of prioritize your medical needs in these appointments. And so in terms of risk, the provider might not prioritize sexual health when we're talking about heart health or cholesterol or blood sugar or all these other sorts of riskier, so to speak, topics. And then, of course, many health providers, one, don't have the language to ask older adults about sex, but then two, don't have the time, and three, might also have their own internalized ageism. Like, is it still really that important, or shouldn't you hang up by now, or really? And so then the patient has a lot of work to do to convince the provider, and that's no fun to be in the role of a patient trying to convince your provider that this is important.
Yeah.
So in that study that I mentioned just a few minutes ago, that 2021 study that surveyed 1,000 adults 65 to 80 years old, they asked them, how often are you having these conversations with your health provider? And the majority said they weren't having them. And I think just less than 18% of the older adults surveyed said that this is a conversation in their healthcare. And that when they did have this conversation, the older adults were the ones to bring it up. And so the provider is not likely to bring it up. And so, and for lots of reasons, right? For the reasons that we just mentioned, maybe it's not a priority to them. Maybe there are other medical conditions that take precedence. Maybe they don't know how to have that conversation. And it just, it takes a long time to negotiate all of that. And so then it's just left out entirely.
So let's talk about, even if they can't manage to have this conversation in these offices, let's understand ourselves what the benefits are, the physical and mental health benefits of an active sex life after 50 and 60. What do we know about this?
Yes, so there are numerous benefits. There are more benefits than risks, I would say, though we can mitigate those risks with condoms and other sorts of sexual activity that are healthy. So the benefits are that they promote cognitive health. So what we know is what's good for the heart is good for the brain. When people are engaging in sexual activity, they generally are able to move their body. So it can be seen as exercise, which is good for the heart and good for the brain. But a study in the last couple of years, I would say probably in the last 4 years, came out that showed that people who are engaging in more frequent, older adults who are engaging in more frequent sexual activity actually scored better on cognitive screeners than those who didn't engage in sexual activity.
Wow.
And we could make some inferences about heart health and brain health. And if you're able to engage in a certain amount of activity, your brain is more likely to be healthy and so on. So that's something. There's also improvements in well-being. There's lower rates of depression, anxiety, and a greater sense of connectedness. For some people, remains a spiritual connection in terms of intimate relationships. There's an interpersonal connection. It can create a sense of meaning and belonging in a person's life, even in the context of illness, right? Like, so I teach a lot about dementia and sexual health. And even in the context of dementia, sexuality can be incredibly beneficial when done in a healthy manner. And so it can reduce challenging behaviors that can come with dementia in terms of agitation or depression and anxiety. And so it has numerous benefits, from psychological health and well-being and spiritual connection and a sense of belonging and interpersonal relatedness to cognitive health and other sorts of physical health.
So do you think this is something that therapists and doctors both should be prescribing, not just opening up a conversation about, but offering this kind of information and actually saying, this is what I see, so I encourage you to go forward? Is there that sort of push, do you think, that's relevant?
Yes. So the recommendation is to talk with older adults about sex. The majority of older adults are sexually active, and we're not talking about it. And by not talking about it, it can reinforce stigma, shame, and the ageist stereotypes that we all have to work hard to I think, exorcise or get out of our systems. because we're indoctrinated with them. And so the way to shift that is to start having conversations and to normalize it.
Okay. Let's talk just briefly about the physical and hormonal changes that are going to affect our senior clients and their sex lives, just so we're sort of, up to speed on what some of those might be.
Sure. Yeah. So we're all familiar with menopause, right? So I'm approaching the arc of menopause myself, but we're all women or cisgender, or some women who, or trans women who still might have the female organs, or non-binary women may still experience menopause, right? So that is a change in hormones. And I think the average age is 50, 51 that people reach menopause. And I kind of call it a crescendo. Like there's a big crescendo of hormones, and there's a change. That change affects our hormones. It also affects our, if I can use, I'll ask consent, right? I'm going to be using some terms that might be triggering for some people. So I'll say, if this is not healthy for you today at this time, you might want to stop listening. But so it can change the vaginal structure of a person's body, and it can change the amount of lubricant that's created physiologically in the body, in the vaginal structure, and that can impact intercourse. For men, there's a process called andropause, and that's a decline of testosterone slowly over time. It affects men differently, and so because of that, that can create a sort of erectile dysfunction or difficulty with erection for men. And that's important because that can impact also sexual functioning over time. It doesn't happen in a crescendo like menopause happens. It happens slowly over time. And so it can be difficult to recognize for men and women, trans and non-binary folks who are interested in maintaining a sex life while this is happening. I would recommend talking with your medical providers about how to do what your body needs in your particular case. Related to andropause, that would require some testing, and it might not just be one unique test. A lot of times medical providers will ask for different testosterone tests at different points in time to really understand the changes in testosterone in a male anatomy body. I would also say there are some recommendations related to menopause for women with female organs to engage, or people with female organs to engage in sexual activity during menopause, because that will actually has been shown to prevent some of the changes that are coming with menopause. So it can help to maintain the structure of the vaginal anatomy, and it can help to, I think even for some folks, reduce risk, and that could then reduce risk for UTIs down the road and all sorts of things.
Oh, great.
Yeah.
So let's kind of coming off of that, are there particular sexual strategies for clients who are coping with these hormonal changes, or maybe other new disabilities that they mightn't have had when they were younger and sort of more actively sexual? Any ways that you can suggest we sort of be able to talk about those issues?
Yeah, so I think what happens, like going back to those ageist ideas for a minute, because this is relevant when we talk about how our body changes. A lot of times we attribute how our body changes to age when it actually is to something unrelated to age. So I'm talking about menopause and andropause now, which is related to age, because it's something that happens in our body over time in the context of aging, and that's normal. And then there are things that happen that we're more vulnerable to as we age, like heart disease, like diabetes, like other kinds of conditions that are more prominent in older adulthood, like Parkinson's disease or dementia disorders. And these conditions, or depression's not normal and not more prominent in aging, but depression can also impact sexual functioning. And so what can happen is that we can acquire a new illness or condition, like a Parkinson's disease or a dementia disorder or heart disease or diabetes, and that can impact sexual functioning as well. especially conditions like Parkinson's disease that impact dopamine, and that can have a direct relationship with our functioning sexually. So then the medications that are used to treat these conditions, even mental health conditions, can impact sexual functioning as well. So those are some things that many older adults are keeping in mind, that changes to the body with heart disease, or changes to the body with diabetes, or changes to the body with Parkinson's, dementia, et cetera. And then the medications used for those. So what I do recommend is for older adults who are, again, interested in sexual activity and living with these conditions or medications for these conditions, is to talk with your physician about optimizing medicines to also optimize your sexual health and fuller life health. So mental health, physical health, sexual health, and so on. I'd also say many people, I worked for a decade with people with spinal cord injuries, and here at the hospital too with spinal cord injuries. And I will say that people who have limitations and adjust to those limitations, there's a period, of course, when we're acquiring an illness or a life-altering injury, that there's a grief process, there's a tremendous amount of loss. And I think part of the healing process, with moving through the grief and loss, is reclaiming identity, understanding a new identity with your new limitations, and then figuring out ways to continue to enjoy life. And when I have worked with people with spinal cord injuries who are adjusted in their spinal cord injury, they can make very creative lovers. So even if for people with spinal cord injuries, there are some things that people can do to maintain erection, for example, or lubricants to help with lubrication. But even outside of that, if that's no longer an interest for people, traditional intercourse is no longer an interest, there are lots of other ways that people engage in sexual activity, and they just get creative. And I think that that's a really important message, is that sexuality and sexual health doesn't have to look one way.
So therapists always love to have case examples, just so they can sort of really think their way through this. Can you give us a case example of a couple or a person who you've worked with who's coming to terms with a different ability at this point and wanting to still be sexually active? Yeah.
Yes. So I worked with an individual who had multiple episodes of prostate cancer, and was now experiencing erectile dysfunction, and was no longer able to have traditional intercourse. And he was really distraught because he and his wife always really enjoyed that style of lovemaking. And I would ask him, well, have you tried all these others? He's like, no, this is the style of lovemaking that I enjoy most. And it was just missionary style, traditional, lovemaking. And he was distraught. He was really upset that, he wanted to have this conversation with his wife. Of course, he suspected that his wife was as distraught as she was. And he didn't quite know how to have this conversation with her. We talked about it, like I said, we grieved a lot of the losses that came from the impact of prostate cancer for him, and the subsequent surgeries and treatments and so on. And over time, and also what that meant to his own sense of masculinity. I think for him, it was part of vitality was the sexual activity and the way that he enjoyed sex. It was a marker of enjoyment, connection, masculinity for him. And so we had a lot of work to do related to those constructs and themes in therapy. And then over time, he thought, okay, well, I want to have this conversation with my wife. And so we would kind of role play what that conversation would look like. And I asked him, well, when are you going to have this conversation? He's like, well, I can't have it on Monday because it's football. I was like, the questions about masculinity in my mind are there are no questions in my mind. And so when he did eventually have this conversation with his wife, it turned out that she was not as beside herself about the loss of intercourse as they once knew it, and that she felt very connected to him and very close to him. They still were very affectionate and romantic and enjoyed time together. And she wasn't as longing for that as he was. That is not always the case. I've worked with couples with Parkinson's who that one member of the relationship is really unable to engage sexually anymore and also has lost interest, and the other member of the relationship is longing for that type of closeness and connection.
Yeah.
It's not always the case that it goes so well. But and so I think that's an important message too, that you'll have one couple with one medical condition, and that will show you one couple with one medical condition and one part of sexual functioning in that relationship and connection. And that's not generalizable to everyone. And I think that's an important message about older adults too, which is that not all older adults are alike. Everybody is different, and everybody's presenting problem will be different. And can you as a therapist be there, attend to it, help them with whatever the arc of their own sexual journey is related to whatever their own sexual health or medical or physical or mental health process is.
In terms of the journey, I love that you brought that up. So are there clients who really are getting much older and still haven't experienced their sexuality in ways that they've always wanted to, who are hoping in these latter years to be able to do that with, or whether that be with a partner or maybe in some other way?
Yeah, Lauren, I was thinking about this, and I wrote a little bit about this in the Psychotherapy Network article too. I was, yes, I will say yes in multiple ways. The two that come to mind that I wrote about in the article were two individuals. Yes, that's the article. Were two individuals who in individual therapy, they were in individual therapy for depression and just kind of changes in their life. Two people came out to me and said that they were in a long-term marriage in a heterosexual relationship. And they both came out to me and said, earlier in my life, I had a same-sex relationship, and I wasn't able to have that as my whole life at that state, at that time. During, when we're working with older adults, there are many generational differences. If you were born in 1940, you were exposed to the McCarthy era, which was very harmful to LGBTQ people. You were exposed to don't ask, don't tell. There was no legalization of same-sex marriage. It was really hostile. It was in the DSM, it was a disorder. And so people weren't safely out. People still, struggle to be safely out. And we have a lot of work to do as a society to create inclusivity and belonging for everyone. And especially the generation ahead of us, or behind, ahead of us, I'd say, the older generation now. And so these two people individually shared with me that they couldn't be out safely for whatever their personal reasons were. And they were longing for the love that they once knew, and that they loved their spouse, and they didn't want to end that marriage, but they also didn't want to face the final chapters of their life without ever knowing the depth of the love that they once knew.
Yeah.
And I see that also in long-term care communities, in the context even of dementia. Mm-hmm. We see that lots of places. I think there wasn't even language. One of the people I was working with was asking me, well, what are the terms? What do each of the terms actually mean? What does LGBTQ actually mean? So we had to have a primer on what LGBTQ is, and how he identified, and if he could even identify, and if that mattered to him. And maybe it didn't matter to him to have a label, but it just mattered to him to have the love and the true experience. And so we had our work to do. He needed information, and he didn't have information. And information like that didn't even exist. There's a great resource, I will say, for LGBTQ older adults. It's free. It's called SAGE USA. Mm-hmm. SAGE stands for support for
aging. It's been a while. Yeah.
Anyway, it's for LGBTQ older adults, and they have free support groups, free hotlines. So if y'all need resources for LGBTQ older adults, sageusa.org, I believe, is your go-to place for that.
I liked how in the article too, Regina, you were trying to make clear that for some people, going into long-term care facilities and being LGBTQ was a very frightening prospect. And so I guess we could talk about that for just a second. So if you're facing a client who is looking at that as a possibility, what are the alternatives? Do you see the care industry coming around a little bit? Is there hope that it would be a welcoming community, or should LGBT clients be looking for LGBTQ communities to try to become a part of as they get older?
Yeah, this is an important and painful. The question is important and the answer is painful. So SAGE USA does research with older LGBTQ folks, and one of the studies or surveys that they did revealed that 34% of older LGBTQ folks are afraid of recloseting themselves or planning to recloset themselves if they move into long-term care. The Diverse Elders Coalition did research with older adults who had moved into long-term care and found that 78% actually did recloset themselves. And so this is incredibly concerning because we're going backwards socially. And I'm working right now. I have a course on dementia and sexual health. It's a certification program. And in my course right now is a large ombudsman group for long-term care. And they were sharing with me, the ombudsman for long-term care, who the role of an ombudsman in long-term care is to be an advocate for the resident, to make sure that the resident's rights are honored and upheld. And so they're often advocates for older adults. And they go into many long-term care communities and help to resolve dilemmas and disputes related to when a resident is saying my rights are being infringed upon, and the long-term care community is saying no, they're not. So they see a lot of the concerns that many residents face. And when I shared with them this statistic, I was like, it's hard for me to wrap my head around that. Yeah. And they shared that the ombudsmen were sharing in this class, no, we see it. We see, and that when people are out, there's quite a lot of harassment.
Yeah. Yeah.
And how incredibly disturbing that is. And so for many LGBTQ older adults, they do prefer moving into LGBTQ focused long-term care community. I think SAGE also is putting together some resources related to that. SAGE also has a legal advocacy group that is working to promote protections, non-discriminatory protections in place for LGBTQ people in senior housing and in long-term care communities as well. I think there's a bill it was passed in the House, and it's sitting in front of the Senate waiting to be heard, I guess, about just generally non-discrimination practices related to renting. That's for everyone, but that would impact in certain states, and that would impact senior housing as well. But then I'm talking more about lesbian and gay older adults or bisexual older adults, but it's even more dire for trans older adults.
Trans folks, yep.
For non-binary folks. And so we know research shows us that when trans and non-binary folks move into long-term care, that when they require assistance with activities of daily living and grooming and showering and bathing and dressing, that there's a lot of hostility and harm and abuse that happens to trans and non-binary older adults. And one of my colleagues, Mark Brennan-Ing, wrote an article discussing the options for many trans and non-binary older adults being euthanasia and suicide over moving into long-term care, which is deplorable.
Yeah.
Which is, I think, a stain on our society, and we have to do better.
Right. Absolutely. I wish we could go on and on. We're almost at time. I did want to ask you, I've heard this from people who work in long-term care, that they do see a lot of STDs in long-term care. It's something that surprises them, but it's really an ongoing problem. So when we're talking about working with seniors, either who have dementia and are still wanting to be sexually active and in long-term care, or not, whether or not they have dementia, should therapists be having the safe sex talk with their clients?
I think so.
Yeah.
I often will. And it's not just STDs are on the rise, and I'll say particular STDs, not HIV, but gonorrhea, syphilis, chlamydia have doubled in the last. I was looking at the statistics last week. They've doubled in the last 20 years, I want to say. But not HIV. HIV is plateaued because we have such great antiretrovirals and great education and public education about HIV. So it's helped to level off the increase of new transmission. But for chlamydia, gonorrhea, and syphilis, yes, they've doubled. So what I would, in the past 20 years, so what I would say is my older adults and outpatient were having sex too. This is not just a long-term care phenomenon.
Right, exactly. Yeah.
Yeah, you go to the villages in Florida, there's a whole code system for intimacy in the villages in Florida. So what I would say is, yes, I often will ask older adults that I work with, do you know where to find condoms? Do you know where to find lubricants? Do you know where to find the resources that you need? When was the last time you had a conversation about sex education? Like what do you know about the transmission of fluids and diseases? And can I share some information with you? Are you open to that? So I'll often bring it up.
I think some therapists would think that their clients would be mortified if they're asking them these kinds of questions. Their older clients would be mortified. But I think you were, at some point, maybe it was in the podcast, you were talking about how we have to remember that this generation that's in long-term care was the generation from the 60s. These are hippies. This is not as if, you're talking with people who haven't been around the block in some ways. So it's good to keep in mind.
Yeah, the baby boomers were the sort of godfathers of the sexual revolution, and they're aging. They're not the only ones in long-term care, memory care. I mean, there are, World War II, the Greatest Generation people are living there. The Vietnam War era folks are living there. Hippies are living there. It's a wide variety of people. Some people may be mortified. Some people may be eager. And I think you can ask. And if the person says, I'm not interested, okay. Yeah. And then you follow their lead. And if the person says, please tell me more, okay, you give more information and resources.
That sounds good. Regina, thank you so much. We could go on for hours about this, but I will refer people to your article in the magazine. Please check it out, you guys, and to her terrific resources as well. So thank you, Regina, so much. And thank you, everybody, for being a part of today's talk.
Thanks so much for having me.